Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. The feature presentation is alternative choices for patients with statin allergies or statin intolerance. I've been a cardiologist for 40 years in the Houston area, so let us begin with the feature presentation. Statins are the main drugs that have been used since the beginning of year 2000. The use of statins between 2001 and 2010 from 20 million people to 40 million people, that is that's in the year 2010, at a cost of almost $20 billion. It is one of the most prescribed drugs for heart patients. However, statins do have side effects. In fact, here are three different studies looking at the number of people who are allergic to statin or who cannot tolerate statins. Overall, there is a 9.1% incidence of statin intolerance. That is a significant number. We are talking about like 1 out of 10 people having statin intolerance. So we definitely need something that is alternative to statin and as good or even better as a statin. And we're going to look at all the different options that are available. But the main thing we want to focus is, why are these patients allergic to statins? And what kind of symptoms do they have? And if you are having allergy or intolerance to statins, what do you look for? So let's look at that one first. The statin side effects are hepatotoxicity. It is damage to your liver. That's why every 6 months, doctors do blood tests to find out if there has been elevation of the liver enzymes. That's how we determine that there has been damage to your liver by statins. Myopathy, which is the most commonly presenting symptom, it is aches and pains in the muscles that is caused by statins. And that is one of the main reasons why people either they want to reduce the dose or stop the statins altogether. Then GI upset like nausea, vomiting, diarrhea. And people who have been on statins for years and years have developed cataracts. And rhabdomyolysis, that is breakdown of the muscle tissue, releasing all these muscle enzymes into the bloodstream. That's called rhabdomyolysis. That is exceedingly rare, and that is not something that you would see. But every cardiologist we have seen like half a dozen cases of varying degrees of this muscle necrosis resulting from statins. And there is also an increased risk of diabetes. So these are some of the side effects, and if you are a cardiology fellow or a resident, then you can use this HMGCRI, which actually stands for the action of statins, which is the statins inhibit the HMG coenzyme reductase. And that's how the acronym is derived. And here's another one which is looking at the same side effects, but using a much easier to remember Lipitor. That is liver effects, increased blood sugar, pain in muscles, impaired memory, tiredness and fatigue, and rhabdomyolysis. So Lipitor is a way to remember all the side effects. But let's look at what are the most important side effects and how frequently do people experience this. Among the people who have statin intolerance, almost 50% of them have muscle aches and pains and some elevation of muscle enzymes. And about 20% of them have gastrointestinal problems, and the others account for a very small percentage. Why do we use statins and what is our goal? Patients with heart disease have increased levels of LDL, the bad cholesterol, which is deposited in the arteries, leading to blockage in the arteries, which causes chest pain, heart attack, and scarring of the heart muscle. The recommended level of a statin for patients with history of known coronary artery disease who have been diagnosed to have coronary artery disease using any kind of test like a stress test or a cardiac catheterization or stent placement or coronary artery bypass surgery, the recommended level of LDL, the bad cholesterol, is around 70 milligram per deciliter. But some of the patients may be walking around with a total cholesterol of 240 and LDL, the bad cholesterol, close to like 150, 160. And to bring that level from 160, 170 all the way to 70 milligram percent, statins have been the main drugs that have been effective in reducing the LDL, the bad cholesterol level, by anywhere from 25 to 40%. And that is why it is so important to understand what are the side effects of statins and what are the alternatives available. And here is a list of the various alternatives that are available to patients who are allergic to statins, starting with bile acid sequestrants, Ezetimibe or Zetia, PCSK9 inhibitors. This is one of the new kids on the block and the most expensive one, of course. And then we have Fibrates, which not only reduces the bad cholesterol but also reduces the triglycerides, the fat circulating in the blood. Niacin, which is actually a over-the-counter vitamin which you can get. Then EPA, which is like an omega-3 fatty acid generally found in fish oil. And we are going to look at all these different agents, how they act, and what are the drugs available in each one of these categories. Let's start off with bile acid sequestrants. These are the drugs which interfere with the bile absorption. The liver produces bile, and that is excreted into the intestine, and later on the intestines absorb the bile, and in the bile there is cholesterol. So the bile acid sequestrants, they absorb the bile acids which contain cholesterol, thus increasing the excretion of cholesterol and reducing the total cholesterol in the body. So there are mainly three drugs available in this category, normally named as questran, cholesterol, and closavalum. So these are available in the form of pills or in the form of powders, which you mix them with a glass of water and drink, especially the questran, and your doctor may prescribe you those medications. Here is an overview of all these different cholesterol sequestering medications, namely questran, cholesterol, and closavalum, or Belcol, you might have heard it, and it interferes with the absorption of bile in the intestines, thus increasing the excretion of cholesterol in the feces, thus reducing the blood cholesterol level and the LDL level also. The ezetimibe, which is a drug which also reduces the cholesterol level. Then we have the PCSK9 inhibitors, which increase the receptors on the liver, which takes up the cholesterol and breaks it into various components, thus reducing the total cholesterol level. This is very effective in reducing the total cholesterol level by 45 to 50%. So if you start off with a LDL cholesterol of 100, it can easily bring it down to less than 50. But the target is 70 milligram per deciliter. Fibrates are the ones which, as I told you before, they reduce the triglyceride levels, the main reason for which they are prescribed, but they also reduce the bad cholesterol, namely the LDL cholesterol. And these have a predisposition for forming gallstones. They also increase the biliary excretion of cholesterol. They can also cause muscle problems, especially when they are combined with statins. The two main drugs that are available in this are fenofibrate and gemfibrozil. Niacin. Niacin acts on the liver by inhibiting the formation of cholesterol. Niacin reduces the total cholesterol level by a marginal percentage, which we're going to look into. And the main side effects of niacin is flushing. It dilates the blood vessels and it causes flushing. EPA, which is eicosapentaenoic acid. Don't worry about it, just call it EPA. It is not the same EPA that you hear about the government. This acts as an antioxidant, and that's it prevents the oxidation of LDL. For the LDL to get into the arterial linings, but first it has to be oxidized. The oxygen has to be added to that, and this EPA prevents the oxidation of the LDL. From free radicals of oxygen in the blood circulation, which are removed by this EPA and other drugs. EPA effects were studied in the Reduce It trial, which demonstrated a 25% reduction, and that is those patients who received this EPA, 4 grams of EPA, along with their regular statins, had a 25% reduction in major cardiovascular events like heart attacks, cardiovascular deaths, stroke, and chest pain, and coronary revascularization. How much each one of these drugs are capable of reducing the cholesterol level by themselves. Ezetimibe can reduce the LDL cholesterol by 15 to 25%. And here's another one, bempedoic acid, which inhibits adenosine triphosphate citrate lysase, which is involved in the genesis of the LDL cholesterol. But anyway, it reduces the LDL cholesterol anywhere between 15 to 20%. When it's combined with the ezetimibe, it can reduce up to 25 to 30%. And these PCSK9 inhibitors, which I told you is the most potent one among non-statin drugs, can reduce the cholesterol, LDL cholesterol by 45 to 60%. There are multiple studies which have looked at the effectiveness of this drug. But this is the most expensive drug. The cost is almost, if you don't have a prescription plan, close to $5,000 to $6,000 a year. That's what it was a few years ago. I don't know what it is when you're watching this particular video. Anyway, putting all this together, here we have bile acid sequestrants, which interferes with the intestinal absorption of cholesterol, thus reducing total cholesterol. It can reduce the cholesterol anywhere between 15 to 30%, and it causes GI symptoms. Ezetimibe, which is generally well tolerated, reduces triglycerides and LDL to a tune of 18 to 25%. And these PCSK9 inhibitors can go up between 50 to 60%, and the most expensive one. Fibrates, just like ezetimibe, reduces triglycerides and LDL by a modest percentage of 10 to 20% of LDL reduction, but they can reduce the triglycerides by 50 to 70%. Niacin has the lowest effectiveness in terms of reducing the LDL cholesterol, but nonetheless, it does do a pretty good job. Same thing with EPA, which is also an expensive drug, and it is an antioxidant. It reduces cholesterol level. It reduces cholesterol level by almost 20-25%, and they have a bleeding tendency. So, can we use a combination of these drugs? Since these drugs act at different locations, in the different pathways of cholesterol synthesis, circulation, and it is possible, I think your doctor has to decide combining these drugs, because if you get 3 drugs, you're going to have side effects on 3 drugs. So that's the main thing that we have to be concerned about, and also the additive effect of these various drugs, which should be taken into consideration. So, ladies and gentlemen, we also need to be concerned about bringing the LDL level too low. Why is too low? The ideal level of LDL, the bad cholesterol is supposed to be 70 milligram per deciliter or 100 ml, and that is for patients with known heart disease. Patients who already have like a stent or a bypass surgery or who had a cardiac cath and they have been shown to have coronary artery disease, their target is 70 milligram percent. But if you drop it considerably lower than that, there is the risk of bleeding, because cholesterol is involved in the maintenance of cellular integrity. That is, to maintain the cells and the connections between cells. The cholesterol is very important in maintaining integrity of the cells and the lining of the arterial walls. And when you reduce the LDL level too much, it can make the blood vessels bleed, which can lead to stroke. Also, the very low LDL cholesterol may be increasing the incidence or risk of infections and sepsis. So these are some of the things that we need to be concerned about. We want to reduce the cholesterol level, thus reducing the cardiovascular events in the future. At the same time, we don't want to be too aggressive in dropping it extremely low. There are people who are walking around with the LDL level of 40, and so we need to be looking at both the advantages and disadvantages. So ladies and gentlemen, this is a very quick overview of alternative choices for patients with statin intolerance or allergies. I am Dr. Nik Nikam, and you have been watching Triple N Media. Please do subscribe to our YouTube channel. We have more than 300 presentations on heart-related topics. Please do watch them, and I will see you in the next video. Thank you so much for watching.